This short wrap-up video will include appendicitis, peritonitis, and obstructions. So when we think about appendicitis, you probably know someone who's had appendicitis, or maybe you've had it yourself. Usually the onset is very sudden. So the patient is going to have that sudden umbilical pain in the right lower quadrant. Sometimes they may have some nausea, some vomiting. The biggest concern with appendicitis is that the appendix will rupture. And if it ruptures or you have a gangrenous tip, like you do here, that can leak into the peritoneum and cause peritonitis, which is the more severe complication, which we'll talk about in a minute. But basically the urgency with appendicitis is to remove the appendix so you do not have to worry about peritonitis and infection. So like I said, signs and symptoms typically is going to be abdominal guarding, pain in this McBurney's point. Patients a lot of times will be laying with their knees flexed when the abdominal muscles are relaxed. Patients feel a little bit more comfortable. You may see some very shallow breathing because they don't want to breathe, they don't want to move, they just kind of want to sit there. So treatment for this will include usually pre-surgical antibiotics, pain medication. We can apply ice packs at the site. We do not use heat. All of that can help decrease the pain. The patient will then have surgery, and typically it's going to be a laparoscopic surgery, so you want to be thinking about all the typical post-op signs or post-op assessments you would be completing. And then, if it's laparoscopic or open, and usually it would only be open if they had some complications, all the post-op assessments and complications you'd be watching for there. So again, very high risk for peritonitis, which comes on our next slides here. So when we have peritonitis, this is happening because we're having localized or general inflammation in the peritoneum. And we have to remember that the peritoneum is a sterile cavity. So this area here is generally sterile. Anything that enters this area and potentially contaminates that area puts you at risk for peritonitis. So obviously if the appendix ruptures or you have a gangrenous appendix, bacteria is entering into that sterile cavity. Any other type of abdominal surgery, patients who have peritoneal dialysis, a stab wound, a gunshot, really anything that can promote bacteria into that peritoneal cavity puts you at risk for peritonitis. And peritonitis, again, is the more deadly complication because it does put you at risk for major fluid and electrolyte shifts, hypovolemic shock, and septic shock, and that's where the lethal part comes in. So usually if someone has peritonitis, they're going to have a sudden onset of pain. The pain is usually severe. They too may also be laying with their knees flexed, having those shallow respirations, trying again to avoid any movement of the abdomen. These patients will need to have antibiotics. In the meantime, they may have NG tubes put down in order to just decompress the bowel, decrease secretions moving through the intestines, pain medication, electrolyte replacement, IV fluid maintenance, just again to keep them preventing hypovolemic shock, and the antibiotics to prevent septic shock. A paracentesis may be done as part of the diagnostic process, but also as part of the treatment. So they'll be able to remove some of the fluid and test it to see if there is, in fact, an infection in the peritoneum. Also, if there is a large buildup of fluid, the paracentesis, similar to like a thoracentesis, can drain the fluid, but this would be draining fluid from the peritoneal cavity. In uncomplicated cases, a paracentesis can be done right at the bedside, or it may be done down in your interventional radiology department. In very complicated cases, it could be done in the OR. If it's done at the bedside, and oftentimes in interventional radiology, there's no real prep for the patient other than having the patient void. And you want to have the patient void because of the close proximity of the bladder. So we would not want to puncture the bladder during paracentesis. But otherwise, the patient is awake. They will drain the fluid, apply a dressing afterwards, hold some pressure afterwards, apply a dressing, and then you would follow any post-procedural instructions that might come along with the procedure. But generally, they might be on bed rest for an hour or two, but there is really no major intervention afterwards. Of course, you'd be watching for any signs and symptoms of infection or complications afterwards. Moving on to intestinal obstructions, these can happen in the small or the large intestine. They can be partial, complete, simple, or strangulated. So usually if you have a partial obstruction, they're going to resolve with some conservative therapy, which means making the patient NPO, possibly inserting an NG tube to suck out the contents before the obstruction, IV fluids to prevent any hypovolemia, and then they'll resolve on their own. If it's a simple obstruction, there is still intact blood supply to the intestine, so therefore it's not an emergency. If at any point there is blood flow obstructed in the intestine, they would need to go to emergent surgery, or they're going to have part of that bowel die. So if someone has a strangulated bowel, typically what that means is that the bowel has kind of wrapped around itself and cut off blood supply to a certain part of the bowel. Or if there is a complete obstruction and there's no blood flow going there, again, that'd be an emergency where they'd need to go in for surgery. If you have an obstruction in your bowels, it can lead to fluid retention in the intestine and then also the abdominal cavity. And this is where you're going to see a reduction in circulating blood flow, and this can lead to that hypovolemia, hypotension, which then leads to hypovolemic shock. So we could see some of these simple problems here can lead to some more complications, which then make the condition more life-threatening. So general signs and symptoms of intestinal obstruction, just kind of in general, again, they can vary by location and type of obstruction, but typically a patient's going to be having some nausea, vomiting, abdominal pain, distension. They're unable to pass gas. Typically at some point they will become constipated, and they may begin to have those signs and symptoms of hypovolemia. So here you kind of have a chart that breaks it down a little bit more as if it was small intestine or large intestine, and if it was the proximal or distal small intestine. So you can kind of see some little bit changes there. So usually if we're talking about small intestine, you're going to have your symptoms, more rapid onset of those symptoms, and that would make sense because it's higher in the GI tract. As it moves down into the large intestine or the colon, it'll take a little longer for those symptoms to show up. And the vomiting, again, that would make sense. If the obstruction is higher, you would be vomiting up those contents because they're closer to the upper GI system, and you'd be throwing up contents. And vomiting may not occur if it's a large intestine obstruction or occur later. Pain will vary in the different locations, and bowel movements, same thing. If the obstruction is higher, you may have bowel movements while you're relieving the stool in the lower part of the intestines, but eventually you'll have absolute constipation. Distension, again, will increase as it becomes lower in the intestines. When you think about bowel sounds, initially your bowel sounds may be hyperactive, and that's because the intestines are trying to overcompensate because things are not moving in one particular location. So you may have an increased bowel sounds or very high-pitched bowel sounds above the obstruction. But eventually there will be no bowel sounds in that area, and that's why it's extremely important to be listening to bowel sounds in all four quadrants of the abdomen. That completes this wrap-up video.